thinking it's because of our lifestyle, right? We are more adapting this kind of lifestyle. We are eating more processed food. Back in the days when we had our grandparents, they were eating from the ground, right?
Yes.
No, everybody's eating KFC, Burger King, and all these processed food. This is what happened the other day with KFC when they had the 50th anniversary. Come on. That's our processed food, salt, right? So MSG and everything. We need to eat more healthy, have a more healthier lifestyle, a more whole food diet, you know? Your fruits and your vegetables and so on. Young people nowadays, everything is processed. Colorectal cancer is quite common. It's the third leading cancer. It's very important that we emphasize screening. And the recommended age for screening is 45 years of age for the average individual, and for person with a family history it's 40 or 10 years earlier for your affected relative, whichever comes first. So we do everything in moderation.
Okay.
Moderation, because we don't know what's happening, right? So as much as possible, you want to reduce alcohol use, want to reduce smoking, and more fruits and vegetables in your diet, be more active, and see. Right? But remember, it's genetic and sporadic. Sporadic meaning it just happened when you don't know why it just happened out of the blues, right?
In Office with Dr. Jevon Samuels.
Welcome to another episode of In Office. I am Dr. Jevon Samuels. In Office with me today is a very special guest. Her name is Dr. Taylor Forbes. Welcome to the show.
Thank you so much for having me, Dr. Samuels.
So, Dr. Taylor Forbes actually is a gastroenterologist. So she did her studies at the University of the West Indies, where he did his DM program in internal medicine. She further went on to McMaster's University in Canada, where she specializes in gastroenterology. So today we'll have a discussion with her about colorectal cancer. But before we get into the interview, Dr. Taylor Forbes, who exactly is a gastroenterologist? What do you guys do?
Thank you so much, Dr. Samuels, for having me today. No, I am a gastroenterologist. So my area of specialty is your esophagus or your swallow tube, your stomach, small intestine, your colon or your large intestine, rectum, all the way down from top to bottom, and also the liver. So any conditions affecting these areas are my area of specialty.
Okay, good. But for this episode, we're going to limit the discussion to colorectal cancer in particular, and colonoscopy, because in all your areas we need several episodes to cover all of that, alright?
Very good.
So, what exactly is colorectal cancer?
So colorectal cancer. So colon, which is your large intestine, rectum, your rectum. So any cancer affecting these areas is what we call colorectal cancer. Now, colorectal cancer is quite common. Actually, it's the third leading cancer worldwide.
Worldwide?
Yes,
Wow.
third. So it's quite common. So there is a need for us to highlight this because of importance is screening for colorectal cancer.
Okay.
Dr. Samuel, screening is very important. No, and it's very important that we emphasize this because right now, based on the recommendations, screening is usually recommended at age 45.
45?
Yes, that's pretty young, or that's what you're saying, that's young.
Yes, that's young, but recently I was reading that the incidence of colorectal cancer is becoming more prevalent, or increasing the young population.
It's quite prevalent.
I know normally they recommend like screening was normally be done like age 50.
The guideline has changed. It's now at 45 because more young people are having basically colorectal cancer. So it has been dropped from 50 to 45 years of age. Now let's focus on screening first and foremost, Dr. Samuels. Now, for the average individual, it's recommended at age 45, right?
Yes.
But for high-risk individual, that is patients who have a very strong family history of colorectal cancer.
Okay.
Having a family history, first-degree relative, that is your mother, your father, your immediate family member, usually screening is recommended at age 40 or 10 years earlier than your first or your youngest affected individual. Whichever comes first, that is what is recommended for your high-risk patient.
Okay.
But average risk patient, screening is recommended at 45. So in the same way you're screening for your prostate and the breast, colorectal cancer, which is third leading cancer, screening is very important. So we want to emphasize that because a lot of people don't know that they should be screening for colorectal cancer. So it's very important.
Okay.
Of note, you need to be asked the screening modalities, correct?
Yes, but before going to the screening modality, I know you mentioned one of the risk factors like family history of colorectal cancer. But we know that family history is a non-modifiable risk factor. But can you just discuss about the modifiable and the non-modifiable risk factors for colorectal?
Right, Dr. Samuels want to jump the gun, want to just go straight at risk factor. But for me, I want to emphasize first and foremost screening, because before we jump to having the cancer and the risk factor, I want persons to screen. So it does prevent it in the first place, right? I think we should want to prevent it before we start talking about symptoms, risk factor, and screening. Screening is more important because if you're screening for colorectal cancer, the incidence will be less or the prevalence will be less. Right? So there's a need for persons to know that they should get their screening done. So first and foremost, screening modalities.
Yes.
So a colonoscopy is the primary investigation or the investigation of choice for colorectal cancer. And you're going to ask me what is a colonoscopy?
Yes,
so a lot of people don't know what a colonoscopy is, correct?
Yes, sure.
No, a colonoscopy is a camera test. So basically your colon or your large intestine, your anus, rectum and large intestine, I use my camera and I insert my camera into all these different areas and I look for any polyp per se. What is a polyp? A polyp is a growth. So usually a polyp is what turns into cancer. So once I do my camera test, which is the colonoscopy, and locate a polyp, that polyp is removed immediately at colonoscopy. So it's a camera test to look for the cancer, to look for polyp. If there's cancer, I'll also do a biopsy of that cancer. So the aim is to catch the cancer, if there's cancer, early, right? So that's a colonoscopy. And usually a colonoscopy is recommended every 10 years, right? So once you do your first colonoscopy, based on my findings, then you will come back to me until another 10 years, right?
But why is that? So why would you need to wait until 10 years? Because it's invasive or what's the reason?
No, because usually we're looking for a polyp, which is a growth. And if you do your first colonoscopy with me and there's no polyp, chances are a next polyp will, a polyp will grow within that time frame. So you will not have a polyp growing in 1 year, 2 years, or 3 years, right? If there's no polyp, right? So the polyp is what we want to look for, because that is what may turn into the cancer, right? So that is what. So once there's no polyp, there's no need for you to come back until 10, because that's the time frame in which the polyp will grow. Understand? So that's colonoscopy, and as I said, every 10 years. Usually, if for example I go into the colon and I find 3 polyps, no, that will determine soon. So based on my findings at the first colonoscopy, that will determine when you'll come back. So I usually send out these polyps or growths to the histology or the pathology, look under the microscope and say, okay, the risk of cancer is very low. So you don't need to come back until 7 to 10 years time. 10 years time. Or so the number of polyp is important and the histology of the polyp and the absence of polyp. So that will determine your timing in terms of when you would. But average and is usually 10 years, every 10 years. Other screening modalities are your stool test. So the FIT test. I don't know if you ever heard about the FIT test. This is a stool test. The fecal immunochemical test. It's done yearly. Right, that's very good. So it's different. So those are 2 stool tests that we use for screening. So the fecal occult blood test, that's done with your executive profile and a yearly. Those 2 tests determine if there's a presence of blood in the stool. So once the fecal occult blood is positive, or the FIT test is positive, you have to do a colonoscopy because I need to look. So looking is the primary investigation, but other modalities, mainly the FIT and the colonoscopy, are the 2 main screening tests for colorectal cancer. Now, other screening tests, Dr. Samuels, You have your CT colonography. That's a CT scan of the
Yes.
colon. That's done every 5 years. But if positive, I still have to do a look test, which is the colonoscopy. You have your flexible sigmoidoscopy as well, and other DNA stool testing that's available. But the primary investigation is my camera test, which is the colonoscopy.
So why is the camera test superior to all the other tests?
Because I'm looking. I'm going into the colon with my camera. I'll be getting direct visualization of the colon, and when doing so, I can do intervention. Meaning, if there's a polyp, I can take out that polyp at colonoscopy. If there's cancer, I'll see it and I'll be able to biopsy the cancer to confirm that this is cancer, because we can't have any form of intervention without first confirming that it's cancer, because it might look like cancer, it might smell like cancer, but it's not cancer. But me taking off a piece, going inside the colon and taking off a piece of that cancer, send it to the pathologist to look under the microscope, then this will confirm cancer, and then we can have intervention. Understand? So that's why the colonoscopy is very important. A lot of people don't know about colonoscopy, but this is the whole purpose of this thing, to educate.
Okay, so colonoscopy can prevent colon cancer?
So it's not preventing colon cancer, because you are trying to find the cancer or find the precancerous polyps or so on. So it's not like you're preventing it, you just want to know. It's a screening test. You want to know if it's there, you want to detect it, and you want to also find precancerous polyps.
Okay.
And you're gonna remove these precancers, so they're not gonna turn into cancer.
Yes.
So it's basically preventing it.
Yeah,
So that's preventing it, in that sense. To find it and to prevent it, because you're removing the polyp. So quite so.
So probably that's why I understand that would be one of the reasons why the colonoscopy is superior to the other tests.
Very good.
The other tests wouldn't be able to remove any polyps.
No, not at all. Right?
Alright.
So that's screening. So we're finished with screening. So we can jump into now your risk factor. Dr. Samuel can't wait. She doesn't want to go straight to the risk factor. Colorectal cancer. So we have prevented the colon cancer by screening. And now we're going to find out what will put you at risk for colorectal cancer.
Yes.
No, first and foremost, we mentioned earlier family history.
Yes.
So having a family history of colorectal cancer puts you at risk, right? Especially a first degree relative, right? Next, you have genetic conditions, right? That excessive polyps in the FAP, we call them, but and Lynch syndrome, these are...
This is a general,
yeah, you don't know about FAP, it's genetic predisposition, family history and genetic predisposition. Secondly, you have things, for example, or diet, red meat and the processed food.
So what exactly referred to as red meat?
You mean red meat, like beef and red meat. As it said, beef, anything that is red and that is a meat is the risk factor. Processed food is also obesity. Sedentary lifestyle, meaning you're inactive. You're not an active person. Alcohol, smoking. These things are all risk factors that put you, at risk for colorectal cancer. So you need to avoid these things, right?
Alright. Does any other bowel condition or
yes, that's very good. I'm happy you asked that question. But so what we call inflammatory bowel disease, that's also a risk factor. When I said inflammatory bowel disease, I'm talking like things like ulcerative colitis, Crohn's disease, right? You might not hear these conditions quite frequent because you see it more in Caucasian as opposed to black. But yes, that's also puts you at risk. As mentioned before we jump to everything, you should also mention about the incidence. Colorectal cancer is more common in black population than white. Yeah? Awesome. More so in males than female. That is also significant as a part of the epidemiology or the incidence of colorectal cancer. So after that, no symptoms, right?
Symptoms.
How are they going to present to us, Dr. Samuel? No.
Okay. I mean, some symptoms that are like, for example, some persons cause blood in the stool.
Very good.
And like some persons we may examine them, might feel a mass in the abdomen, and some persons.
Very rarely you find a feel a mass, Dr. Samuels. No, the mass are. So of course you mentioned rectal bleeding, blood in the stool, right? That's the most important. You're not supposed to have blood in the stool. Then abdominal pain. Yes, pain. Not supposed to be having pain. What's going on? Next is an altered bowel habit, bowel movement, changing your bowel movement. Something is wrong, right? Now, with colorectal cancer, also you can have spread. So if it's spread, you're gonna have symptoms. So it's spread to the liver, You might feel the liver that is enlarged, or you feel something in the location of the liver, right? Next, it can go to the lungs. Started having shortness of breath or so on, right? Because it's spread to the lung. So depends, and you don't wanna, when it reached that stage, that's when you're knowing that you have colorectal cancer. So that's why we mentioned the screening
and
first.
actually, I've seen a patient that had presented with symptomatic anemia, like
anemia.
blood
So iron deficiency anemia, very good. Is also because you don't know why you're anemic, right? So that means you're losing blood. So iron deficiency anemia. Also, they can have obstruction, right? Especially if the tumor is on the left side, in the lumen, obstruction symptoms, nausea, vomiting, abdomen distended, right?
Okay.
That also can be presenting symptoms for colorectal cancer, right? So most commonly. And also unexplained weight loss. You're just losing weight and you don't know why you're losing weight, right?
Sure.
That's also a significant symptom. So that's symptoms.
Symptoms, alright? And now if we think about, for example, can probably go into some management for, I want to discuss colonoscopy, for example, like the whole bowel prep and why they fail, but
so first and foremost, once we suspect that this patient has colorectal cancer.
yes.
Of course, as mentioned before, we have to do a colonoscopy, camera test. Now, as you know, the colon is where there's stool.
Yes.
So I have to give you a washout before I can go, because if the colon is blocked with stool, I won't be able to see anything.
Yes.
So usually we give a laxative days before the procedure is done.
How many days we're looking at?
So it varies for each individual, right? So remember, you have individuals, for example, have some old people who cannot, it's a 4 liter, so you have different preparation.
Okay.
Yeah, you have the peg light and the pico Celilac. So I like to use the peg light as my laxative, right?
Why you prefer the peg light?
Because it's a 4 liter, so it's 4 powders, you put in a 4 liter solution.
Okay.
So you have to drink that 4 liter. As opposed to other preparation like the pico prep. It's like use 150 mils of water with the powder, and you can have the privilege of drinking any form of clear fluid. I don't like that. When you have to drink the entire 4 liters of the peg light, you're more disciplined, so you have to drink the 4 liter. Okay. But when I give you the option of drinking any clear fluid of choice from the pico Celilac, you might not drink. And I need to have a clean bowel because you want me to be able to see. You invite me to your house, you want me to your house to look nice and clean, right? If I come in there. So I like that kind of laxative. But it varies with each gastroenterologist. Whatever your choice is, at the end of the day, I need to have a clean bowel.
Yes. But it seems like the bowel prep, a lot of patients don't do it properly. Because even recently was a patient on the ward that failed the prep 2 times. Like both times when they went, the bowl wasn't prepared.
Did they drink the solution, Dr. Sandra? That's the question.
Okay.
And in addition to drinking that solution, you also have to hydrate yourself with clear fluids.
Okay.
And so sometimes you have to stretch out how we clean the bowl, because you need to clean the bowl. So everybody is different, right? If you're not drinking the solution, you will not get a clean bowl. And you mentioned the word.
I think there was some.
You know the situation on the word.
Yes, but I think some patient like complain that it tastes bad, like it doesn't taste.
No, it's not about the taste, it's more about the volume. Probably you should get one and drink Dr. Samuel to get an idea. Right? He should drink one.
Because I'm so
it's more about volume.
I'm approaching the screening age.
Right, he's approaching the screening age.
Approaching the screening age to test it out. But normally some of the patients, they probably think that colonoscopy is too invasive. They have to put them to sleep or sedate them.
Yeah.
And what are like probably some of the complications of it? Because even I'm a doctor and I'm probably a little bit scared about it myself.
Of course, yes. So first of course, mention about the prep the day before, which is the washout. I do believe that is the most challenging part of preparing for a colonoscopy, because you'll be in the bathroom for the entire day. You understand? For patients who are, we have to consider also different factors for patients. If you have heart failure, how are you going to drink the 4 liter solution? If you have kidney failure, how are you going to drink the 4? So you can't one size fit all. It depends on the patient. Old people, they can't maybe drink it, so you have to stretch it out over a period of time for people who cannot drink all of that, in such a short space of time. So the washout I think is the most challenging part. Now on the day of the procedure, I usually give sedation, right? Make it as comfortable as possible. Because as you mentioned, it's invasive, that's invasive, that'll be going into the colon, so you need to be as comfortable as possible. So I give sedation before I do the procedure. Then I insert my camera in the anus, rectum, colon, and I go to the very end of the colon, cecum. Sometimes I go into the small intestine or the terminal ileum, and I'm looking, right? So I need to have a clean, so I can have clear visualization of every corner, every nook and cranny, everywhere. I need to see clearly. And you don't want to miss a polyp or anything like that, because as I said, polyp can turn into cancer. So you don't want to miss anything at all. I want to see clearly. So you need to come to me with a clean bowl for me to see, right? Clearly. So.
Alright, you said that like colon cancer is the third
leading cancer, breast and prostate. You know,
common in terms of the incidence or in terms of death, not death, though, just the
cancer, the overall cancer
amount of cancer. Yeah.
Yes.
But and it's a preventable cancer. So is there like any government policy that would kind of encourage everyone to get screened at that age? Because it's not as popular, in my opinion, like how we have breast cancer and cervical cancer. Those two cancers, then most patients they have a high get.
So I think that's the problem, and that's why we're doing this right now, because us as clinicians need to put it out there more. March was Colorectal Cancer Awareness Month. So yeah, March recently. So as clinician, it's our responsibility to educate. So just like everything, you have programs and you have brochure, pamphlet, everything out there for breast cancer and prostate cancer. So we need to more, to have proper forum to educate. I went to the gym the other day and I was telling a man, asking him, when was your last colonoscopy? He thought I was talking about his prostate.
Really?
So you see, there is a need for us to educate. So this is the purpose of this forum. So we need more of this forum to educate people about colorectal cancer, because as I'm saying, it is quite common lately.
Okay. So in terms of the cost, because for example, breast cancer, prostate cancer, and cervical cancer, I think the screening tests for those tend to be a little bit less expensive than say a colonoscopy. So probably even though some person might can get it in the government system for free, probably the amount of gastroenterologists that we have plus the machine, it would not be feasible to screen the entire population with that method.
Colonoscopy. So that's why we talk about the stool testing that way, which is quite common. Everybody's doing a fecal occult blood test. So there's a FIT test and a fecal occult blood test. Usually you need more than one fecal occult blood test. But anyway, you're testing for blood in the stool, right? Now, for the FIT test versus the fecal occult blood test, the disadvantage for the FIT test is more ideal than the fecal occult blood test, because fecal occult blood test is affected by your diet, medication use, and those, but the FIT test is not. So the FIT test is more recommended than the fecal occult blood test. But I find that the fecal occult blood test is more readily available here in Jamaica. It's a part of the executive profile. So maybe there is a need for us to add the FIT test to the executive profile rather than the fecal occult blood test. Right. Yeah. And also to have more GPs, administering the fecal occult blood test. Rather than wait until you're doing an executive profile to do your fecal occult blood test. The general practitioner must make it a part of their routine where, Mr. Jevon, when was your last stool test, and you administer, this can be administered in the office. So there's a need to educate more people about these tests and make them more accessible, right? So I guess that will then emphasize, or should I say, put it out there more about colorectal cancer and its prevalence. So we have so I did the colonoscopy and I find a mass. So I biopsy, meaning I take off a piece of that sample and I send it to the pathologist. Because as I mentioned before, you have to first confirm it histologically, meaning under the microscope. So once that is done, I send it off. Then I have other investigation that I need to do, because first thing I want to know what the hemoglobin is for this patient, because bleeding can be a factor, so I want to know the hemoglobin. So I'll send the patient to do a complete blood count. Then I also send the patient to do a urine electrolyte, which is a kidney test. We're going to be administering medication or something, so I need to know the status of the kidney, what all the kidneys are functioning. Then I would send the patient to a liver function test. Because remember, colorectal cancer can spread to the liver. So I want to know the status of the liver. And then you have other tests, the CEA and so on. That's how we know what to send the patient for. But most importantly, I need to stage this.
Yes, I can discuss staging now, just in case we didn't we didn't
Staging
do
is
a
very important.
colonoscopy and miss.
No, you mean you have to do the colonoscopy?
No, I'm saying that
after the colonoscopy, we're going to stage Dr.
Yes.
Samuel. Staging, we need to know the extent of this cancer. So I would send patients to do a CT chest, abdomen, and pelvis because I want to know, is this cancer confined to the colon or the rectum, or is it involving the liver, or is it involving the perineum, or is it involving the lung? So the CT scan will give me that information because that will determine how I will treat this patient. No, you want to catch this cancer at the early stage when it is confined to the colon.
Yes.
That's the best time you want to catch it, okay? So when it's confined to the colon, so after I find the cancer, a biopsy, confirm that it's cancer, do my staging investigation, do my other investigation, then I'm going to refer you to the surgeon and the oncologist for them to make the decision as to, is this a patient a candidate for surgery, or is this patient a candidate for chemotherapy or radiation, or chemo and radiation. So you see, so that will determine treatment. Staging will determine the mode of treatment or the method of treatment. Now, if it is confined to the colon,
Yes.
good. So surgery, you would resect the area that is affected and that colon that is affected. That's good. So you get that area and you're fine. But the problem is if there is spread,
Yes.
then you're gonna need chemotherapy. If the rectum is involved, radiation.
Okay. And in turn, what's the 5-year survival for somebody is spread?
That's it. You see what these
No,
doctors
no,
are?
we-
They're just quick to jump to survival rate. And we're not gonna be talking about when you're gonna die, right? We're not gonna mention that. Right now, Dr. Samuel, we want people to know about this colorectal. Dr. Samuel is ready when you're ready for dead already. We're not going to go there yet. We're not going to be there.
Because this program about life sickness and death.
No, we don't reach there science. No, we're not ready for the realistic thing yet. People that ready to tell you when you're going to live. Oh, we have a 5-year survival rate of 10% or 3%. No, we're not going to go there, okay? Thank you so much.
We're going to prevent it from farming.
We're going to prevent it from farming in the first place. So that is the aim. We don't want to know when it's too bad and it's too far gone and we can do nothing about it, right?
Okay.
So that is the most important thing, you know. And also, what is important to Dr. Samuels is genetic testing.
Genetic testing.
Yeah, because as I would mention before, you have some genetic condition that put you at risk for colorectal cancer.
Okay.
So if you discover that one particular family member has the particular genes, then usually we would recommend sending you off other family members to get these genes or genetic testing to see how best we can help or diagnose colorectal cancer early.
Okay.
Because as I said, there are specific genes that put you at risk for colorectal cancer.
So we normally screen those persons.
Yeah, so if you find one individual with this particular condition, the FAP and the links that we mentioned earlier, every family member, we usually send them for the gene to test if they have that particular gene, so we know what to do from early on. We can monitor them constantly before colorectal cancer develops.
Alright. And where so the incident was like getting higher in young persons. Do we have any explanation for this in the research?
So, in my mind, I'm thinking it's because of our lifestyle, right? We are more adapting this kind of lifestyle. We are eating more processed food. Back in the days when we had our grandparents, they were eating from the ground, right?
Yes.
No, everybody's eating KFC, Burger King, and all these processed food. This is what happened the other day with KFC when they had the 50th anniversary. Come on. That's all processed food, salt, right? So MSG and everything. We need to eat more healthy, have a more healthier lifestyle, a more whole food diet, your fruits and your vegetables and so on. Young people nowadays, everything is processed, right? So I'm thinking that's why we're not eating how we're supposed to eat. Everybody's smoking now, everybody drinking alcohol now. Come on. Not that they never used to do that back in the days, right? With our older generation. But I'm thinking now it's more of our diet, what we're eating, and we're not as active as we used to. Because think about it, your grandfather used to go in the bush and go a farm and dig in ground and so on. Well, but he may not eat or he not eat.
He healthy.
He not eat healthy. Grown provision. Right? Right. When you go down, even down at Cape Bridge, everybody tell them can't afford the fruits and vegetables. Right? Everybody constipated and they can't eat fruits and vegetables. So they're eating the flour and all these things and that makes them constipated.
Okay.
So I think that is the problem. Or lifestyle.
Lifestyle.
I think so, the lifestyle.
And obesity as well.
Obesity, sedentary lifestyle, red meat. Well, everybody know on Instagram meat, red beef. Everybody eating beef now. All these influencers and the fitness person beef, because you want the protein, the high protein in the beef. You don't see that right now, Dr. Samuel?
Yes, definitely I'm seeing it. But I'm saying that, so is there a recommendation that person should stop eating beef?
We're not saying stop eating, but everything, reduce. You should do everything in moderation.
Okay.
Moderation, because we don't know what's happening, right? So as much as possible, you want to reduce alcohol use, want to reduce smoking, and more fruits and vegetables in your diet, be more active, and see, right? But remember, it's genetic and sporadic. Sporadic meaning it just happened and you don't know why it just happened out of the blues, right?
Okay, alright, sure.
So,
alright, so I guess we're coming to the end, but normally a part of this program I allow the guests to advertise whatever business they are doing, and also to give a summary of what was discussed, and last final statement to encourage the persons about whatever we have discussed. So we can just give one final comment about colon cancer and colonoscopy and screening.
So in summary, colorectal cancer is quite common. It's the third leading cancer. It's very important that we emphasize screening, and the recommended age for screening is 45 years of age for the average individual, and for person with a family history it's 40 or 10 years earlier for your affected relative, whichever comes first. Important screening modalities: colonoscopy is very important, done 10 yearly, stool tests, spit tests, fecal occult blood tests. Screening modalities are all there. We just need to do one of them to see how best we can prevent colorectal cancer. The risk factor for colorectal cancer, the modifiable and the non-modifiable risk factor. Your family history is one that you can't modify, can't modify. But things like smoking, your diet, red meat, being obese, having a sedentary lifestyle, risk factor. Patient, for example, should look out for symptoms. Blood in the stool, never a good sign. Having abdominal pain, changing your bowel habit, iron deficiency, anemia, having abdominal distension. Something is wrong. You know that something is wrong. That's also a symptom of colorectal cancer. Once you notice there's something going on, get your colonoscopy done. Colonoscopy are available everywhere. Probably limiting factor maybe just the cost and the accessibility. Do your colonoscopy, get the proper investigation done so we can, get proper treatment, proper therapy, so you can have a long and healthy life. Now, one thing I didn't mention, Dr. Samuel, you mentioned about complication from colonoscopy. I didn't want to go into that because I don't want to scare people from doing a colonoscopy. You need to just know that it should be done, and it's a very important test. But we don't want to go into when you're gonna die if you have colorectal cancer, complication of colonoscopy, because that just might prevent you from doing the colonoscopy in the first place or getting screening for colorectal cancer.
Okay.
Thanks for having me. So I'm Dr. Taylor Forbes. I'm the gastroenterologist. I'm the gastroenterologist at Kingston Public Hospital. I also do private work at Epion Medical. I do procedures at the Tony Place Wing and also at Portmore Hospital Complex. If you need further information, you need to be educated more, you can call me at 399-7157 or Epion Medical. Thank you so much for having me, and I hope to see you quite soon. And remember, get your screening done for colorectal cancer. Thank you.
Thank you very much, Dr. Taylor. So viewers, remember to share, like, subscribe, and leave a comment on this video. And colorectal cancer, as I discussed, is the third leading cancer worldwide. So it's essential that, and it's a preventable cancer as we have discussed today. So I'm encouraging everyone, if they're at the age of 40, 45, to start thinking about doing a colonoscopy. And also, if they have family members that have colon cancer, then they should seek the screening at an earlier age, as we discussed on this program. Alright? So kindly share this video with others so that we all can be informed about colon cancer and colonoscopy. Until next episode, stay tuned.
Be sure to subscribe for more informative contents on life, sickness, and death.